Hello, everybody. My name is Brian Sonenstein, and I am the co-founder of Shadowproof. I'm joined today by Jon Walker. Jon is a journalist who covers healthcare policy and drug policy. He's the author of After Legalization, Understanding the Future of Marijuana Policy. You can read his writing at pendinghorizon.com. And Jon recently wrote a single-payer proposal for us here at Shadowproof. It's called MICA. And we're going to talk to Jon today to have him expand a little bit on the bill and what it does and bring some greater understanding to the plan that he put together. And in addition to that, we're going to talk about some of the critiques that we've gotten of MICA and, some of the different ways of doing things and the feedback that we've gotten. So, Jon, just to begin, I was wondering if you could just tell us sort of the impetus for writing this, the motivation behind it, and sort of how you got here.
All right, yeah. So we are probably heading to a very important moment in about 3 years. We will probably see a Democratic Party elected in at least the House in 2018, and you got a good chance of seeing a Democrat elected in the White House in 2020. And there's usually sort of a brief moment after a party wins big where they've got a chance to push through major legislation. We saw this with George Bush with his tax cuts. We saw this with Obama with the Affordable Care Act. We saw it just now with the GOP trying to push through repeal and replace and barely failing at that. So this is an effort to get the conversation started now to work out the details of a healthcare plan for that moment, because there's not enough time in that brief window to put together all the details and work through all the problems. That needs to be done well ahead of time. With the ACA, you had hospitals and insurers and a bunch of other groups all organizing around trying to come up with a plan like that. They had been laying the groundwork for that for years before it actually made it to Congress. So that is the impetus for why I put together this now, and the conversation I sort of hope to start with it. And it's all about getting this discussion going to address all these issues before sort of the moment of action comes. Because if that window is missed, it'll probably be another 4, 5, 10 years before sort of another moment for something like this comes up.
Right. And, I wonder if you could talk a little bit about this as well. Some people might say, well, there is a bill, that's introduced pretty much every session for Medicare for All. In Congress. There was the plan in California that recently got held up. Why did you decide to write this plan, and why did you decide to do it at the federal level?
All right. Well, there's the reason I decided to write the plan as it is. Most of the plans you've seen so far have been about messaging, about building popular support for the idea of single-payer healthcare. And that's good. That sort of needs to be done, and that work has been done for years. But we are now transitioning from the point where you don't just raise general support for the idea, you got to raise it for a specific proposal. I saw this in the marijuana legalization field. MPP and other groups put up different bills on the ballot. They failed because people were like, we don't like this provision, we don't like how this is done. And then they went back to the drawing board and, rewrote those provisions, changed some things. And they had to do that several times before they finally coalesced around an actual plan with real details that could get passed.
Right.
If you look in the California bill, they didn't even have a funding source in it. And that was relentlessly attacked because they're like, how are you going to pay for this? And they didn't, have a good answer. The one in Congress right now, the Medicare For All plan, I think it's a great plan. I think it's sort of a very good thing to say this is the ideal of what we want. That has a lot of giant sort of hurdles politically that it would run into that I don't think are battles worth dying on over.
Right.
And the reason I wrote it at the federal level is it's just so much easier. There is ERISA, which sort of prevents states from regulating employer-sponsored insurance, which is a big chunk of the entire private market. There's also just the issue of countercyclical spending. During a recession, people still need healthcare, but they don't have jobs and they're paying less in taxes. And at the federal level, that's fine. We can borrow, money during a downturn. that's easy. At a state level, you got to balance the budget every year or every 2 years, however the states are designed. And that becomes a real problem to build that into a system. That sort of just creates another layer of complexity on the complexity of the healthcare system.
Right. So let's dig into it then. Let's just get started and talk about the bill. It's called the Medical Insurance and Care for All Program, or MICA. You can find it on Shadowproof. John, why don't you just start out by giving us a general breakdown on what the bill does?
All right. So the bill would basically create a Medicare-like program that everyone would automatically be eligible for. Would work that if you don't have insurance through your employer, you're automatically on this plan, and you automatically have a sort of tax applied or a premium charge, however you sort of want to define it. And then you just get this sort of immediate, very good basic public health care. If you want to go and buy some private insurance, you can do that with your own money. That we won't stop you from doing that, but I don't think most people want to do that. Doesn't make sense for most people. If you're very wealthy, you want sort of a private doctor that gets flown in to see you. That's something you can do. And if you currently have employer health care, the rules changed so that employers have to at least provide you something as good as MICA. They provide you MICA, or if they don't do any of that, they have to pay a fee into a fund that pays for MICA for everybody. So it's a fairly simple and straightforward way to work kind of within the confines we have currently to a system where everyone is automatically qualified for good basic public health insurance.
And so why, one thing that I saw come up when people read this was your decision to expand employer, do it through the employer market. Can you talk a little bit about that and why you chose that approach as opposed to say the lowering the age?
To do something as big as SinglePayer or any sort of healthcare reform, there's going to be some people that are automatically opposed to it. The insurers, the hospitals, the drug makers, they're going to be making less money when you sort of put price control on it. They're going to oppose any plan. But there's sort of an other nebulous set of people who don't like change or might lose out if you change the tax structure of how you're paying for different things. Those people you can win over if you do it right, or you can lose if you do it wrong. And that is really directed to those people. My plan is basically about taking the money, which is currently going to the healthcare industry. We pay much for healthcare as like the UK does. And basically taking that money and sort of redirecting it back to all the regular people. So the plan is to make everyone that's sort of not the healthcare industry better off. Trying to radically change things. I'm just trying to make everything better off for people in a way they're semi-familiar with.
Right. And so can you talk, another thing that people are immediately concerned about is that we're not completely abolishing the private insurance industry, at the get-go. And I'm wondering if you could talk both about the decision to do that and sort of the politics and the political strategy that are ingrained in this bill, and what they would do to maybe shrink the industry or change the kind of coverage that they can provide now. Like, what would the private insurance industry look like, after MICA was implemented?
Yes. So I think it's important for people to look at other healthcare systems they want to be like. And one thing you do when you look at some of these very socialized single payer type systems is none of them have completely done away with private insurance. In the UK, in Denmark, in Canada, they either have supplemental policies or they got these private insurance policies that you can get through your employer that guarantee you quicker, faster access to doctors, private hospital beds, those types of things. I think the idea that you're going to completely get rid of the private insurance market is just like when looking at other countries. And I also think it would create a lot of anger trying to do something that other countries haven't done, because that's not what should be the main focus. The main focus is making sure everyone has basic access to care. So what what the law would do is it would, one, make all private insurance sold have to be as good as MICA. And the MICA plan is probably way better, cost sharing, coverage wise, than say 95% of all employer plans currently out there.
Mm-hmm.
So it's going to have to be very good. And it's going to have to be competing against this basic public health insurance plan. You can look at Australia as sort of an example of this. Most people are covered by this basic insurance plan, and they're very happy with it. If you've got extra money, you want to get things better, because there's always going to be someone who wants to get things better. Shutting the door on that, trying to shut the door on that, just doesn't seem to make sense. Well, that's why we're doing it. And the other level is, look at how angry people were when Obama promised no one loses their current plan. And some people did. I don't feel there's any need to actually, quote unquote, force people off their employer coverage if they claim to really, really like it. What you're just going to have is this alternative for employers to choose that could be way better. But then that's the employer switching over. It's not the government making you do it.
Right.
And I think that's really important to get the politics of it right.
Right. Definitely. To that question, I wonder if you could just expand on this a little bit more. I think a lot of the concern, as soon as people see that there's any private insurance, they're like, well, then the motivation is still around profits. There's still going to be that motivation to price gouge and things like that. And I know that you talked about, some of the ways that, based on the standards of MICA, that wouldn't be possible. But could you touch on, what, how MICA would make things better off for people who need healthcare most? A lot of the hopes and dreams of the Affordable Care Act were pinned on providing insurance to people who really needed it. And I just think that's a major motivating point for a lot of people. So if you could talk about that.
Yeah, so this program would make sure everybody who is, in the country, within the confines of the law, is automatically qualified for what is a very good healthcare plan. Basically, the MICA is like Medicare, except for with several of Medicare problems fixed. Lower copays, lower cost sharing issues. There's a limit on out-of-pocket costs and all those things, which Medicare doesn't have. A government-run drug program. Medicare's got a Medicare Part D thing, which is a wasteful, silly private market nonsense. So effectively, everybody, regardless of what's happening to them, regardless of their income, regardless of anything else, has this insurance automatically. And the only reason they would not have this insurance is because they have a better private plan. There's always going to be people on the top end who are going to use their money to buy better things, whether it's better insurance or just entirely private healthcare practices that we currently have in this country, which don't even take insurance at all and are just purely for rich people to pay out of pocket for everything. There's always going to be that in basically anything. But the issue is creating this system with no gaps, no holes in it. Everybody gets it. Nobody will run into affordable problems. That is a big problem with the Affordable Care Act. Not only are there holes in it, but the people who are quote unquote covered by the program face these crazy deductibles that makes it very unusable. And that is all addressed.
And what I really appreciate about this is that a lot of this comes from the standpoint, or what are the trade-offs that we have to make? And like you said, when we started, it's time to put rubber to the road. It's time to stop talking about messaging and start talking about what are the political obstacles, especially as you put forth different proposals. What opponents does that create? What opposition does that create? And one of the things that I saw a lot of people asking about was a zero cost system. And I know I talked to you about this a little bit. You had some rationale for having things like copays and other things like that. But I was wondering if you could talk about what some of the trade-offs would be with having like a zero cost insurance system where healthcare was basically free. Does that exist anywhere? Just talk about that a little bit, because I saw a lot of people being like, well, this still makes people pay for insurance, for healthcare.
Yeah. So one thing to keep in mind is there's no healthcare system out there that's truly zero cost. Most healthcare systems out there, like Canada and Britain, they usually have something you're paying for, whether it's over-the-counter medication, prescription medication in some places, dental in Denmark. A bunch of single payers actually have some modest copays, either on, different things. And the reason I went with some very small and limited copays is that I know how the CBO works when it comes to determining the costs that they'll estimate for policies. And a no copay system would probably come across as scoring maybe 15, 20% higher by the CBO. I don't think that would be accurate. I don't think it would be that bad, but I don't think it is worth dying on that hill because you don't want a copay of $20. And the copays would be structured so that if you're making very little money, you effectively have no copays. But I think it's not unreasonable that if you're a middle-class family, $20 copay to visit a specialist or something of that nature, that's far more than the copays I currently have under my current plan.
Right.
So, that is a debate worth having. That is something we sort of collectively need to decide. I don't think it's sort of worth that, bigger price tag, because that is also something that can always be changed after the fact too.
Right. Yeah, and similarly, you kind of touched on it a little bit there, but a lot of people are also asking about the means testing strategy in there. And I've talked to you a little bit about this, and I think you have some interesting thoughts. Why include means testing in here? If you could talk a little bit about that specifically.
Yeah, the means testing in the bill is very modest because the actual copays are very modest too. And so the question you run into is, again, this sort of goes back to a lot of sort of CBO scores and studies that show some little out-of-pocket incentive. You kind of want someone to first try over-the-counter Claritin or something before going to the doctor to ask about a problem, because that's just cheaper. If you don't have a little mild incentive for people to do that, the CBO will score it as costing a lot more. But if you add in those mild incentives, you don't add in means testing, you're just hurting this very, very low end. So I do think it is reasonable that, we're talking about copays that the average person collectively in a year would probably add up to maybe $200, $300, $400 at the most. And I think that's reasonable for most middle-class families. There are some very poor people on the low end that's not reasonable for. And so the question is, would you rather create a system to help a few people on the low end with this small problem, or would you rather make it flat for everybody at a dramatic sort of cost projection? I don't think it would increase costs that much, but the cost projections, the CBO would say, which could really scuttle the entire effort. And so I think it's worth the trade-off, personally.
Got it. Great. I think moving on, the next question I want to ask you, when this was being shared around by some healthcare journalists, I saw some people putting, the word single payer in quotes, or saying this is single payer like. I was wondering if you could respond to that and sort of give your thoughts on, the idea of quote unquote true single payer in that regard.
Yeah, I think we've got a problem with how people use language. There is one theoretical definition of single payer, and that's where nobody except for the government pays for absolutely anything in healthcare. And that doesn't exist anywhere. In Canada, people pay for some prescription medicines, they pay for dental, there's insurance companies that cover some costs not covered by the insurance company. In the UK, there's some private insurance companies by employers. People still buy Band-Aids. People still pay for facelifts or boo jobs out of cost. That's not covered by the government. So using that as sort of a definition of single payer is kind of worthless in discussions. I'd be happy if we used 80 different terms to describe every single healthcare system, but that's just sort of not practical in political sense. So my interpretation of single payer And the one that I think is most widely shared when people are talking about it is one where everybody automatically qualifies for a government-run insurance program that doesn't exclude the fact that if people want to pay more for some additional private care, or if people were paying some costs for some things, cosmetic surgery is not covered by basically all, healthcare systems out there for good reason. I think that is the definition to go with. If you're saying this isn't single payer, you're basically saying, Denmark's not single payer, Australia's not single payer. Basically, every country we consider single payer is not single payer. And I just don't think that's a helpful definition for discussing politics.
I completely agree with that. Moving on, another question. There's a couple other areas that I wanted to just get your clarification and your thoughts on. One of them comes under eligibility, where we talk about how automatic enrollment in MICA is limited to citizens and legal residents. Could you talk about the decision to do that and some of the, sort of the challenge in confronting healthcare for undocumented immigrants, and whether or not, this might be a place to do it?
Yeah, I believe it is important. We are talking about taking on a major industry that's that's 17% of the economy. And I think it is important to keep the healthcare fight focused on the healthcare fight. And there's a real desire by some groups to try to include in the healthcare fight sort of all other fights, replace the current way we pay for things with a progressive tax code, and deal with issues of immigration and everything. And I think that just leads to it being bogged down. And ultimately, when it comes to something like undocumented immigrants, you can't really address that piecemeal. Because even if you say someone qualifies for a program, what is stopping, a Trump after being elected being like, oh, you signed up for this, indicating you're undocumented, we can just sort of pick you up. You have to deal with undocumented immigration as an issue. Now, if you pass this single payer bill, you've created a simple and easy path to immediately deal with that aspect of it. And if you pass this before, if you pass, immigration reform before this, it's not an issue. And I think it is critical to sort of focus on sort of one task at hand and try to not make this into the amalgamation of every dream and every hope in one place.
Definitely. Another area that I'm curious to hear your thoughts about is on the subject of reproductive rights and reproductive health care. What would be the interplay between something like this and the Hyde Amendment, and how would that sort of shape the battle on healthcare reform moving forward?
Well, one, I think people bring up this issue, and I don't know how much it really would be, because I have a tough time believing that if we elected a Democratic Congress prepared to move forward with a plan like this, that it would be anti-choice at the same time. So I think it's sort of less of a concern than people often talk about, just if we're projecting forward into the future. The other thing is, there are more abortions paid for by public health insurance plans in this country than there are private health insurance plans. Most private health insurance plans don't really cover non-sort of Hyde approved abortions. And even if they do, almost every insurance plan out there now in the employer market has significant deductibles. So the irony is that even under this plan, even if there was a Hyde Amendment, covering everything, you're still likely that a woman seeking an abortion would still probably pay less for healthcare that year under this plan than they would currently. So I think that's a little bit of, it's become a real sort of ideological thing, but you really have to look at a breakdown of the numbers of how it's happening. And yeah, it's very rare to actually wind up in a situation like that, with private insurance actually providing really good paying for abortion, because most women with private insurance who went to get an abortion paid for it all out of pocket, did not have it covered by their insurance.
My last question for you, before I want to open it up to you to sort of just talk about your hopes for this and where you see it potentially going. And I think we touched on this a little bit earlier when we were talking about the Medicare for All bill in Congress and the California bill, but specifically the federal Medicare for All bill. Can you talk just about specifically the benefits and versus the pitfalls of doing the employer strategy versus lowering the age? Specifically, like what are some of the risks of going the route of lowering the age?
Yeah, I would support lowering the age. Don't get me wrong. I support all these ideas. I just want us to rally around what is the most feasible way of getting it done. And I think you run into a problem with lowering the age that the drug makers and the hospitals don't oppose single payer because they don't like government-run health insurance. They would actually enjoy having a simplified bill processing issue. They oppose it because they oppose any kind of cost control. And so they would oppose the cost control measures you see in a place like Switzerland or Denmark, not Denmark, the Netherlands, where they use a regulated private insurance system with big cost controls. So they are going to oppose anything that pushes cost controls on them. And if you lower the Medicare age, they are going to likely fight that just as hard as they would Medicare for All, except now you've got a plan that only benefits a smaller slice of the people with the same amount of opposition against it. So I think that's one problem you face going that route. I think the other problem you face going that route is there will be sort of a highly disruptive tipping point, most likely. Let's say you can probably lower the Medicaid age a few years, sort of nothing changes. Let's say once you get to the point where you've lowered the Medicaid age to like 45, then a bunch of employers maybe just decide to stop dropping coverage. Almost all their employers are over 45. They're getting, Medicare through this. So you'd see maybe a mass sort of dropping of coverage in the market. Then you kind of need an immediate fix because everything's sort of getting overwhacked. Everything's getting changed over. People are getting very upset. People do not like disruption. Even if it's eventually leading to a positive end, most people are going about their day-to-day lives, telling them, oh, 3 years from now, this will get lowered again, then you'll be covered. That's not going to make people happy. And I think the other issue with going the lowering is you'll need to create a new tax to pay for that Medicare as you're lowering the age. And then you've got this system where you're benefiting these older people and kind of whatever tax you're applying, unless you're like creating a very specific tax only for older people, you're likely going to create a system where you're going to create some people who are losers, some maybe younger people who are paying some of the tax, even if they're younger rich people. You're going to create this new class of losers that is going to create another subset of opposition in addition to the healthcare industry. And I don't think that is effective politics, given how big of a challenge we're facing.
I think those are all really great points. I would just like to leave it to you now to sort of sum up, your thoughts on this, what you hope will come of it. And, additionally, if anybody's listening and they're like, what can I do to help with this plan or to, maybe get more eyes on it, any of your thoughts there would be great.
Getting more eyes on it, just sharing it around to your friends and family, sharing it with your elected officials, telling them you support this, telling just different groups that you might be a part of, that you want to start talking seriously about this. People can attend their local Democratic conventions, their local sort of Democratic meetings or something, and, suggest putting things like this on their platform on a local level and on a state level. Because building support, takes a long sort of lead time to create like a tipping point. And it's all about preparing for that moment where there's a chance for Democrats to take action. And my sort of final thoughts about it is I'm not saying this is the plan we have to go with. I'm saying we need to think sort of item by item, what is it that we want? And what I want is a universal healthcare system where everyone's assured basic coverage is affordable. And I think this is the best way to actually achieve that. And I'm open to hearing other options, but they have to explain why. Their plan not only is just better policy, but why they think it has a chance. And I think this plan has a chance because what it does is, instead of trying to redefine how we do taxes and redefine everything else while redefining our healthcare system, it basically takes what everyone's currently paying for healthcare, just makes it less, and gives them better healthcare, because we reform the healthcare industry, which is just in terrible shape, just ripping off people, not designed to help people maximum, really focused on profits. So it is all about taking that industry and then redirecting money from that to people, but within a way that they're used to. And I think that is our best hope.
Thank you so much, John. You can read the bill at shadowproof.com. The title is Medical Insurance and Care for All, a National Single-Payer Bill. You can find Jon Walker on Twitter at Jon Walker DC. You can read his work at Shadowproof and Pending Horizon. John, thank you so much for doing this, and I look forward to reading more of your work.
Yeah, thanks for having me on.